I think we can go ahead, no?
Yes. Dr. Ashujan, we're all set to go ahead. Yes.
Should I start?
Yes, please.
Namaskar. Welcome to this 9th edition of Raipur Obstetric Gynec Society and Society of Fetal Medicine webinar, which is, as you all know, by experts. It is always by experts. And today the topic that we are going to discuss is when to do a sonography. This is a question that is asked by most patients, and we do not have an answer which is backed by a great deal of facts. Each doctor has their own view of, when a sonography should be done, depending on local expertise available. So now today we are going to learn by Dr. Khurana sir and his extremely expert panel about what is the ideal, what is the standard, when should a sonography be done. So welcome Dr. Khurana sir. I don't think he needs any introduction. Khurana sir, Sahani sir, Dr. Vaishali, Dr. Chinmay, who is almost a part of Raipur Gynec Society, Dr. Vandana Bansal. Welcome all of you. Dr. TL and Praveen sir. And over to you, sir.
Thank you. Thank you very much. And yet another evening with Raipur as our base, but the world as our little oyster shell, if I can call it that. There's been much excitement about what's next in Raipur. And people often ask me, where are you coming up with these topics from? And I must confess, these topics are being inspired by two people. One is Dr. Asha Jain, who is constantly saying, this is not what we need to learn. We need to be more pure clinical. I said, wonderful, let me think about it. And then Dr. Bimal Sani, who constantly says, what we really need to do is to come and accept the harsh reality of ultrasound in India today. And therefore, we need to make sure that this consists of a series of questions or topics that are going to be heard by a large audience, not just the people who attend the webinar, but people who actually come onto YouTube afterwards to watch this, and then to realize that things change frequently, but there is a certain stability in what we do. And therefore, today's topic is again far from what was originally envisaged for today when we planned all this out in December last year. December last year, we thought we would discuss invasive placenta today, but we realized that invasive placenta concerns a few of us some of the time. But doing an ultrasound correctly in terms of its timing seems to be far more important, and we have to get that message across. And therefore, our plan for today, for the next 1 hour, is this. I'm going to get my screen share on, and here we go. And do let me know if all of you can see this. Are my slides visible?
Yes, sir.
Wonderful. And so my pointer is visible as well.
Yes,
so
sir.
What we're going to do today is to put all of this together and try and see where we can put this most important topic of timing and ultrasound correctly. And we will take you through from early pregnancy all the way up to delivery. I will be supported in my answers by Dr. TL and Praveen, our president, who needs no introduction, Dr. Bimal Sani, who is our president-elect for next year for 2 years and needs no introduction again, Dr. Chinmay Rath, whom everyone knows is universally one of our most popular academicians and makes sure that we drive the point home correctly and that there is no theory to it. She's based in Hyderabad, but is well known to all of us. Dr. Vandana Bansal is from Mumbai, and you know that she can handle anything academic from basics to right on top, but also importantly knows exactly what each aspect of ultrasound, genetics, clinical medicine, etc. needs to be driven so that we can get our points home correctly. And then, of course, Vaishali Munde, who is for the first time on our Raipur program. She has been practicing in various parts of India, but currently now settled in Nagpur, where she spearheads renovation of the ultrasound and the fetal medicine mind. Thank you, Vaishali, for joining us today, and thanks to all the other panelists. Our very first question to start off with, and this is for Dr. Chinmay Rath. Could you please tell us, why is it important to date a pregnancy, and what is the best period of gestation to date a pregnancy?
Thank you. Thank you very much, sir. And thank you, Asha Jain ma'am, for again bringing us all to Raipur. Why is it important to date a pregnancy? Well, because the whole pregnancy is a time-bound phenomenon. We know that at one point a conceptus takes a shelter into the womb, which we call as the uterus, and the placenta is formed, and the placenta has a fixed lifespan. So after a certain time, it will stop working. And if we don't salvage that pregnancy, it will lead to a non-viable fetus. So everything in pregnancy works to a timeline, and there is a date that is very essential. We need to know what is the date of the pregnancy, because we need to know how far we are in pregnancy and when it's likely to be ending. So dating is beyond doubt. Everything that you do in pregnancy is relevant only when you date it. So what investigations you will be doing, what scans you will be doing, how you're going to take obstetric decisions, everything is bound to the dates. You cannot terminate a pregnancy if it crosses a certain date based on the current law. You can do a biochemical screening, but it will only be interpreted if you date it correctly. You can do biometry, but it will only be interpreted if you date correctly. So I think we have to date a pregnancy. Now, what is the best period to date a pregnancy? The period when it's unequivocal. Whatever you choose as your biometric parameter should not be subject to a lot of controversy. So the first trimester is the best time, and within the first trimester also, I would dare to say that the 11 to 12 weeks period is the best time, when actually you are able to see the fetus in a mid-sagittal section in a neutral position, and you are able to allocate a CRL, which has a very good reproducibility when many people do it. Early pregnancy also is a good time. The only problem we face sometimes is if it's not taken correctly. Instead of a longitudinal view, if somebody has taken a transverse or an oblique view of the fetus, sometimes you tend to underestimate the age in the early pregnancy. But the first trimester of pregnancy is the best time to date. And I would say the 11 to 14 weeks period is the best time to at least confirm the dates, even if you allocate it early on.
Wonderful. So that gets the ball rolling. And we move on to our next question. And this is for Dr. Bimal Sani. Dr. Bimal Sani, how should a crown rump length be measured? How is the result expressed? Weeks and days, millimeters, estimated date of delivery. And then within that 11 to 14 weeks window, should we prefer scans at 11 plus weeks, at 12 to 13 weeks, or 13 plus weeks? And one most important question, what are the points an obstetrician should look for in an image to ensure that a good quality study has been done? So it's actually 4 questions in one, and here we go.
Yes, sir. As far as the first part, like how should we measure a CRL? Now, see, we all follow very stringent criteria on how we should measure an NT, but I would say equally important is a very stringent criteria as between the 11 to 13 weeks, 6 days on how we should measure the CRL. So there are strict guidelines regarding that. So there are 5 points that we need to consider in the image. That it should be magnified so that it's at least 2/3 of the screen should be occupied by the fetus. Then it should be a mid-sagittal view. So you should not be seeing the stomach or the heart. You should see the profile, you should see the spine and the rump. Then the third important thing is that you need to have the image should be horizontal. The fetus should be horizontal to the ultrasound beam, and the head should be in a neutral position. That means that there should be some amount of fluid between the chin and the thorax. So there should be some amount of fluid. So the head should neither be hyperflexed nor hyperextended. And then when you put in the calipers, then the calipers placement should be from the outer aspect of the skin of the head to the rump, and then we should not be including any part of the extremities in that. And then, of course, the guidelines say that you need to take 3 images and 3 measurements, and you can take an average of that. You can do that, or whichever you feel is the most appropriate image, you can follow that. Your second part of the question is, at between the 11 to 14 weeks window, when would I prefer that? I think the best time would be to do it between 12 to 13 weeks. because then we know that the NT and all are more sensitive towards the early part of this window period, whereas structural evaluation is better when we do it later. So as a compromise, or not as a compromise, but finding a midway, so between 12 to 13 weeks would be an ideal time when I would like to do this scan. And as far as how we need to report that, definitely the most important amongst all the 3 points that you said is the millimeters. So there is no point, of course, you give what is the weeks and the days, but if you just give the weeks and the days, and if you don't give what is the measurement of the CRL, then I think we have gone absolutely wrong, because we know that NT is a function of the CRL. So we need to have the measurement. So your complete first trimester screening, combined screening goes for a toss if you don't have the measurement of the CRL. So that actually is the most important factor. And then when it comes to what should an obstetrician look into when they see whether this, the scan has been done perfectly. Of course, as I said about the CRL, yes, this is the criteria that I said. You need to see whether the image is showing all this. And then because it's 11 to 14 weeks, 11 to 13 weeks, 6 days scan, look at the NT image, whether it is well magnified, you have a proper, mid-sag, there is no zygoma seen, and then the caliper placements of the nuchal translucency and the neutral position. So all these things will become important. And we have actually distributed from the Society of Fetal Medicine a good NT image on a paperweight. And I think if everyone can have it on their table and just look at the image and compare it with that, they would be sure whether the results have been done properly. So I think if anyone has taken a good magnified image and is a mid-sag with a neutral position, that means the person who has done that job knows his job. And I think that should give enough confidence to the obstetrician that whatever results are coming from this are quite accurate.
Excellent. Thanks so much. Now, my next question is for Dr. Vaishali. Once the dating scan has been done in the first trimester, should dates be changed in subsequent scans?
Accurate dating of the pregnancy is very important to improve the outcomes. We all know that by convention, EDD is 280 days after the first day of LMP. This is what we use in pregnancy wheels. So once the pregnancy has been dated in the first trimester, you have to see the data. That is LMP, is it accurate? Then is the EDD given by the ultrasound and is the EDD given by the LMP is matching? And whether it is CRL is measured in the stage when it was an embryo or it was at the stage of first trimester ultrasound, and whether the CRL is measured where the baby was measuring beyond 84 millimeters. So if the pregnancy is redated properly, as sir has already explained to us, there is no need to redate the pregnancy in the second trimester. However, dating in the second trimester, there are few guidelines on the dating in the second trimester, as in when to date the pregnancy in the second trimester if we don't know the EDD by first trimester scan or by the when the LMP is unsure. So if LMP is greater than 5 days before 9 weeks, then we can redate the pregnancy. Greater than 7 days from 9 to 15 weeks, 6 days. Greater than 10 days from 16 weeks to 21 weeks, 6 days. Greater than 14 days from 22 weeks to 27 weeks, 6 days. And greater than 21 days after 28 weeks of gestation. However, we should consider that as we progress towards the near term or in the late trimester, the redating is very much inaccurate.
Wonderful. So we should just stick to a date that's allotted right in the beginning, and never ever change it if we find that the embryo size or the fetal size is completely different.
Yes, correct.
Wonderful. Thank you for that answer. Dr. Vandana Bansal, how should twins be dated?
So twins, the importance is much more than in singleton. So whatever Dr. Bimal Sahni and Chinmay has spoken, yes, twins, you need to date them accurately because they may have a higher chance of preterm We want to know exactly the gestation. Even to know about aneuploidy, we want to know the CRLs to understand that. So in twins pregnancy, if it is an embryo transfer, so if it is an IVF conception, then we will follow the embryo transfer date. And that also in the embryo transfer, it could be a 5-day fetus or it could be a 3-day fetus. So you'll have to take that into account. But if it is a spontaneous conception, then you would follow the CRL of the larger twin, because the larger twin, you cannot have a large for gestational age in the first trimester. You could have a small for gestational age in the first trimester. So you would follow the CRL of the larger twin to decide on what to date the pregnancies with. And for aneuploidy, the NT is as important as the CRL. So the CRL has to be correctly taken for the singleton as well as for twins, because everything is dependent as much on the NT as much on the CRL. So embryo transfer dates, you follow embryo dates. If it is spontaneous, you follow the larger twin CRL to date the pregnancy, and you follow that throughout the pregnancy. You do not redate them again. So.
Excellent. So there is absolutely no doubt in this, and there is, so far in the discussion today, we've had absolutely no gray zone. It's very straightforward about all the concepts that we have discussed. Moving on to our next bit, let's see what answers we have from Dr. TLM Praveen about dating for the first time in the second trimester. The patient hasn't received any attention until that time. She hasn't gone for medical attention. So how do you date a pregnancy at this stage when the patient comes to you? Is it just the head circumference alone or something more, and how do we go about it?
Yeah. Thank you, Ashok, for involving me in this webinar. Now, most important thing in the second trimester, I think we need to cultivate the habit of checking the CRLs if it is available by the previous scans. Because as it has been made very evident that once a proper CRL has been taken, that becomes the baseline, which helps us to date the pregnancy, and we are not supposed to change the dating once it is dated by CRL. Now, in case if the patient has come to you without any CRL, or that is going to be the first scan, remember always that there is a biological variation which catches up after 12 weeks of gestation. So keeping that in mind, there are multiple parameters that are taken into consideration as far as the second trimester dating is concerned. As we all know, we all keep doing it every day, like taking the biparietal diameter, head circumference, abdominal circumference, as well as the fetal femur length, or any long bone measurement for that matter of fact. Basically, most important thing that we need to understand is that these parameters have to be appropriately taken with the standard fundamental landmarks being followed. Like, for example, if it is a biparietal diameter transthalamic, AC, you need to get the umbilical vein and the porto-umbilical junction. Fetal femur length, avoiding involving the distal femoral line. So these are the parameters that we have to keep in mind while dating. Now, in spite of all these things, sometimes, I mean, not sometimes, that particularly in the second trimester, because of the biological variation, there can be plus or minus about 1 week or more than 1 week sometimes. But then there is one more parameter that we somehow depend upon, or maybe very useful, is the TCD, that is the transcerebellar distance, which usually corresponds in millimeters to the weeks of gestation. So there is one thing that we need to keep in mind. But one most important thing I would suggest, I would practice, is that whenever I have this sort of a situation, when I am not very sure about the gestation age that has been assigned based on these biometric parameters, I would definitely like to call them back after 2 weeks to reassess the growth pattern, at least, so that once the growth pattern is available, at least you know that you are in the right path, and you know appropriate gestation age can be assigned, as well as the expected date of delivery can be assigned at that juncture. I think this is what I follow in my practice.
Yes. Perfect. One question, sometimes when we look at old reports that were done in early pregnancy, we find that the CRL may not be mentioned, but there is a mean sac diameter in our first trimester report. How reliable does that become?
I think we should. It's not appropriate to base on that to take the mean sac diameter, because there is a lot of variation. The reason is The mean sac diameter can be interfered or influenced by various factors. One, if you have a distended bladder, it can compress and vary the diameter. Two, if you are using increased pressure over the uterus, then also it can vary. So it's a variable factor which can be influenced by various extraneous factors. So that's the reason why we don't depend on the mean sac diameter in assigning the gestational age or the expected date of delivery.
Thank you. Thank you so much for that. And we move on to next question. Dr. Bimal Sani, if the patient comes to you for the first time in the third trimester, and I know this happens to you all the time because you have such a major referral practice, how do you date the pregnancy?
I would not like to be caught into this kind of a situation in life, sir. If where the patient is coming, okay, if they're coming to me for the first time in the third trimester, it's okay. But if they've not got any scan done before, that becomes a very, very tricky situation. Of course, the first and foremost thing, if they're coming to me for the first time in the third trimester, I will look into the older reports. I will look into the images if possible, so that I know whether the dating has been done properly. And then, of course, Praveen sir has already pointed out that, yes, we all have been saying that CRL is the best. So if all that is available, I am in a comfort zone. I'm going to date the pregnancy according to that, and then see whether my parameters today fall within the normal range, within the normal centile for that particular gestational age. The question comes is, if the patient has not got any scan done before, or is coming, it doesn't usually happen these days, but then, at times, especially during this COVID period, we found that, yes, patients missed a lot of those early scans and they landed up in the first time. So the most important thing is dating in the third trimester is always going to be a suboptimal dating. That we all have to accept, and that is something we need to document also. So then, of course, we don't use the multiple parameter gestational age assessment as far as dating is concerned in the third trimester. What we, so it's a very tricky situation, sir. We need to look at the profile of the patient. We need to look at their own height and everything, because there was a time we thought that the femur length is a better predictor of gestational age in the third trimester. If the head is lower down, if it's an cephalic presentation, you may not get a good head perimeter or head circumference. In 2005, there was a study which said that you can use a combination of head circumference and femur length, and a combination of that would be a decent enough for assigning a gestational age. But then we are probably, in all these, we are going to underestimate the gestational age if we do a dating in the third trimester, if it is an FGR fetus. And that is where we need to use some internal check mechanisms, like transverse cerebellar diameter is one thing that you can use as an internal check. You can use the distal femoral epiphysis, the proximal tibial epiphysis, and later in the third trimester, you can also use the proximal humeral epiphysis. So they all have a timeline. So like we know that the distal femoral epiphysis, though you may start seeing in some percentage from 29 to 30 weeks, but then usually 32 and always by 34 weeks. So if you're seeing a distal femoral epiphysis, it tentatively tells us that, yes, there is a possibility that, this is definitely at least more than 32 weeks. So you can use this. You have to use all these things to, as an internal check to come up to a as accurate, closer to the normal gestational age. And then we talked about the mean sac diameter. From practical experiences, I'll tell you, maybe the patient may say they have not undergone any ultrasound before because there has been no reporting as such. But then if you look into the files, somewhere in the early part of the pregnancy, on the letterhead, somewhere in the corner, there is a mean sac diameter written or something that can give you a tentative clue that you are, what gestational age this is. Then you can use femur length, the foot length also. So all these parameters you need to look for, and then come and then do document that there are no earlier dating scans. There's no dating scan or earlier scan available. the parameters based on the, or the biometry based on the head circumference and the femur length corresponds to so and so. Today, datings done in the third trimester are suboptimal. That is something which we need to mention in our report.
Wonderful. Thanks so much. So we're now all set to say, okay, this is what we're sure of, and this is what we need to consider for serial evaluation. My next question is for Dr. Chinmay. We often come across reports which say ultrasound composite age or composite ultrasound age, which is an average of everything that we measured. What is the logic of this, and really should we you be using this kind of a method at all?
There's a logic to everything, and there's a logic to being illogical also. So the point is, when we do this composite ultrasound age by the machine, like you very rightly pointed out, it's just the average of the biometry, which the machine puts together and allocates gestational age. Now, if the machines were that intelligent, and if it was legal for the machine to allocate gestational age or even offer treatment, it would have been like that. But the patient does not come to see the machine. The patient comes to see the doctor. And therefore, it is the final responsibility is the doctors to give the gestational age and compare the biometry for that gestational age to the patient. So what the machine does is it just calculates biometry. Whatever is the biometry, it fits it to a gestational age. Now, the problems is, like Dr. Bimal just told us, you don't know if this is microcephaly, that head circumference does not correspond to 28 weeks. It's actually a 32-weeker fetus who has a 28 weeks head circumference. So that is incorrect. If it's growth restriction, the entire dating gets reallocated to another gestational age, and that can be disastrous. So, well, it's not wrong for the machine to do that. But try and understand this. I remember from my school reports once, I got scolded by the teacher for getting 16 out of 20, and another child got lauded by the teacher for getting 12 out of 20. Now, we both got different marks. I got 16 out of 20, the other person got 12 out of 20. But the teacher told him, very good improvement. And to me, she said, why have you lost those 4 marks? So because everybody has a different parameter against which they are judged. So when you assign the dates in the first trimester and your fetus is now 32 weeks, whereas it is supposed to be 28 weeks, you know this is a large for dates baby, and this baby is not, it doesn't have the maturity of a 28-weeker, but it has the body of a 32-weeker. And if you deliver that thinking it is 40 weeks when it is actually 36 weeks, you will be landing up in prematurity. So you cannot do that. We have asserted very early in this discussion that dating has to be fixed once and for all. Thereafter, the onus is on the fetus to grow as per those dates. If the machine starts allocating biometry, you will start imagining that the woman conceived the head on one day, the abdomen another day, and the femur yet another day, because sometimes the gestational age of the head is weeks away from the abdomen and weeks away from the femur. That doesn't happen like that. And everybody has one composite date, which should be nothing but the date which is allocated in the early pregnancy plan. If we are caught in that weird situation where our women have not had any antenatal checkup or any ultrasound scan till the 3rd trimester, I think all of us would feel very ashamed of that situation, because throughout COVID, throughout everything, all medical services were open. So there is really no excuse for any patient to say that we could not have had an ultrasound scan. And anybody who knows is pregnant had access to an obstetrician, and every obstetrician has to understand whether or not you do the last scan, please do the first scan. So an early pregnancy scan is very important. That has to be done. Thereafter, use your machines to do the biometry, but use your brains to make the final report. Please don't report whatever is given on the machine just because it's easy to print it out.
Wonderful. Thank you for clarifying that for us. And moving on to our next question. And this next question is for Dr. Vaishali. In resource-restricted scenarios, when should a pregnancy be dated? And my question is basically reflecting the fact that if we look at the recommendations of the Government of India Ministry of Health 4 years ago, the only scan that they ever recommend is a mid-trimester anomaly scan at 18 to 20 weeks of pregnancy. So can we really skip this, or do you think it's even more important to make sure that we do our homework correctly in these situations?
Really, it's a very tricky question, sir. Where there are, at present, I feel there are, in all restricted scenarios, we should consider that assessment of gestational age by all these parameters are proxy markers of true gestational age. And we should know what are the strengths and weaknesses of each method for the consideration. So here, when there are no early first trimester scans available and we have only one chance to do second trimester anomaly scan from 18 to 24 weeks, I'll do the redating or dating of the scan earliest as possible, that is at 18 weeks. Because as I have already told, as we move towards late gestation, the accuracy of the dating decreases.
But would you agree that we must insist that irrespective of the fact that one scan is allowed, we would be really saving so much money by dating a pregnancy accurately, because we don't know the end of pregnancy. So irrespective of what the government says or doesn't say, we need to, of course, fight at that level and say that, look, we have to have this registration scan. The patient comes to us and we do it. But should we compromise like that at all?
I don't think we should compromise, because we all are getting trained by different national, international bodies. And in the present era, there is no excuse for losing such an important information.
Yes. So I think you're absolutely right that although we would like to do it as early during the anomaly scan, but ideally speaking, we can tell the patient that, look, it's not covered for you. It's not something we can do in this particular hospital, but we think we should be doing it. Would my panel agree with me on that we just should not compromise? Yes, Bimal.
Yeah, sir, if at all you've not done an early pregnancy scan, it's okay. But I think one scan, so like Dr. Vandana and Dr. Chinmay also brought out the 11 to 14 week scan is good enough. Okay, you've not had any scan before that, it's okay. But the 11 to 14 weeks, because it's definitely good for dating, good for see the kind of information the 11 to 14 week scan gives today is huge.
Yeah.
And I think that has to be an integral part. I'm not saying definitely 19 to 20, the mid-trimester anomaly scan is important, but the 11 to 14 week scan is equally important.
And I think we have to also, sir, as a society, reach out to the government and tell them to rewrite the rules in the wake of the new evidence and the new expertise that's available. Because when they insisted on the mid-trimester scan, the whole emphasis was on looking at the anomalies. But now we know that apart from anomalies, so many other things are also important, and it's feasible and practical to screen for all of them. So that 11 to 14 week scan can be the first recommended scan even by the government also.
Absolutely, I fully agree, because even if you look just at the incidence of preeclampsia, it's more than the incidence of all anomalies put together. And it's something where we can actually do something. Whereas in the anomalies, we have limited options.
Very limited, and multiple pregnancy for that matter.
So this is precisely what we have placed before the ministry. And we do hope that we have a stable ministry for the next year and a half, so that before the next elections, we can push through at least this agenda and say, look, we are ready with this new committee that will put this together. So I'm very hopeful this should work out. But I'm sure we're all in agreement that we really must follow this particular system in this particular way. Now, that brings us to our next question, and that is that Dr. Bansal, lack of access to medical attention is often likely in some parts of the country and in many communities where people just don't think. Like I remember when I was growing up, the 5th month, it was quite traditional to visit a doctor for the first time. Thank God we've come a long way since then. But there's some patients who might come once and never come back again. So do you think it's a wise idea that we should just, at any time that the patient comes in, the first time in pregnancy, should we just go ahead and make sure that we do a scan, then complete the dating and whatever else can be done?
Sir, I think we need to look at affordability, availability, and whether that patient is going to come back. So even in a medical college like mine, where patients were earlier coming in the second trimester directly, now patients are more aware and they start coming in the early gestation. So I would still say that 11 to 13 weeks is the time I would want one scan which will take care of aneuploidy, look at twins, look at cervical length, look at uterine artery Doppler for preeclampsia. So not that I would do a scan for every patient who comes in on the first visit, but I can counsel them that you need an important scan, which is an 11 to 13 plus week scan. So maybe in villages where you don't have facilities for patients to come back, it might be okay to ask for a one scan to know the dating of pregnancy early. But I would still counsel all patients that you do an 11 to 13 week scan and then come for an anomaly scan. So instead of one scan in the whole pregnancy, at least two scans in pregnancy is what we need to put down in the guidelines. One, your 11 to 13 and your anomaly scan. Another thing what Chinmay was saying, sir, just to add on to how gynecologists read reports of composite gestational age, sir. You'll get a report of a composite gestational age, and next time I will write it according to software of changing it to whatever we are following by brains. So they would say that was 32 weeks, and now you are saying 36 weeks, and we give centiles along with this. So the obstetricians have to be trained to understand that this composite gestational age which the machine gives is not the gestational age, and you need to look at centiles rather than this. So there is a lot of frictions when you give centiles and don't give the composite gestational age, and people have to get educated on starting looking at centiles in the weeks of gestation.
Yes.
And I think SSM is doing excellent in getting everybody together to learn that.
Yeah. So we must Dr. Praveen's and Dr. Bimal's output. Dr. Praveen first.
Basically, I think this habit of giving a composite dating is not really should be encouraged. I think it creates a lot of confusion. Let all of us stand and stick to a point that the first trimester scan, particularly the 12-week scan, is an extremely important scan, not only for dating, not only for aneuploidy, not only for structural assessment, and not only for preeclampsia. So when there are so many benefits that we are going to get by doing one particular scan, I think it's time that we insist. And then once you start insisting and giving them the appropriate, exact expected date or the date the pregnancy based on this parameter, I think this question of composite date confusion will not arise at all. I think that's one thing that we have to, this message has to be very clearly sent across, saying that there is no question of composite dating, and that creates more problem because you can't expect the leg to be delivered on one day and head to be delivered on the other day. So I think we need to be, that message has to be very, very clear and sound.
Wonderful.
Sir, what I was trying to say is like it's very important that everyone understands that the size and age are two very different things. Yes, we use the size to assign an age in certain situations where the LMP is not known or they have irregular periods and all those things. But once we have determined that this is the age today, the age always is going to be as per the number of weeks that have passed after that. So like very simple thing, if a child is 6 months today, after 6 months, the child is going to be 1 year. Whether the child looks 9 months or child looks 1.5 years, it doesn't matter. You can't change, you can't say that this child is 9 months because it's, and I think that this whole issue about, the dates being changed and everything happens with all those 4455 EDDs that you see across is happening because of one basic reason, and that is that look back into the file. And I think it is very important for obstetricians also that if they've got an earlier scan done in the first trimester, the EDD that has been given at that time, they should put it in large at the top of the file, because that becomes the most important thing to follow after that, sir. So
can I just make one point, sir, here?
Yes, Chinmay.
So what has already been said, I just want to put it into a practical perspective that everywhere we don't have softwares. I normally use a software to do the reporting. So we just take the actual values, put it in the software, and the software tells us how the baby is doing in terms of centiles, like Dr. Vandana said, the centiles that we need. Suppose I don't have a software and I'm going to work only with a machine. That is where the dichotomy comes, because most people think that on the machine, we can't generate these graphs and we can't reorganize this. But let me tell you, when you book your patient on the machine, there are options. So if you put LMP there, it automatically calculates an EDD, and whatever you take as a measurement, the machine calculates its own measurement and gives you a different centile for that. But actually, if you stick to the EDD there and you manually enter the EDD, whatever you have taken in the early pregnancy scan, and then do your measurements, the machine will calculate the composite gestational age, because that has been told to calculate that. I don't know, sir, whether we can disable that as such. But then for your allotted EDD, it will also calculate centiles with various charts there, and you can continue to use the same patient ID and generate even continuum charts to say follow up for growth and other things without any fancy software. So that is very much possible, and we do it.
Yes. So the question is that EDD gets fixed. Yes, Dr. T.R. Praveen.
Yeah. See, another important thing is, see, all our machines have got what is called as a past history. When you have the past history column, you can fill that column as you have filled the EDD which has been assigned by the CRL. In the same way, the past history where you have all the biometric parameters, you put them on, the graphic representation becomes much more appropriate, and you get correct percentiles by entering the past history. And the machine automatically takes the present biometric parameters and calculates the percentage. I think that is one habit that we should cultivate, so that at least we will be able to generate appropriate growth charts.
Absolutely. Yeah. Yes, Piman.
And it's also very important that when we write in the impression that this is the gestational age, it's very important to write down, from how you have derived this gestational age. Like, okay, single fetus of a gestational age of 20 weeks, 2 days, then the gestational age assigned as per CRL done on so and so date. Or if you have done it by the current biometry, there is nothing else, then gestational age assigned as per the head circumference, or a head circumference and the femur length, whatever. I think that reduces a lot of confusion for the obstetricians, especially in the third trimester, where they say, okay, all your parameters are showing 30, 32, 1 weeks, and you are writing down 34 weeks down in your impression. So it is important to stress how you have derived this age of the fetus.
Hello. Sir, I would like to add a point that EDD is like a fixed wall, and the gestational age is how much distance you have crossed from a certain level till that wall. You cannot keep on pushing and pulling the wall every time you make the measurements. That's why it should be fixed, and we should know how much further distance we have to cross.
Excellent. Which makes it very clear that we need that late first trimester window, and that we will never change the EDD after that. And we will specifically mention in our report, this is where we got our EDD from, and we will not use averages.
And just one small point, so sorry to stall you here, but then this is another thing. Apart from obstetricians, the other people with whom we have a fight with gestational age is the labs. Now, I have a real problem with second trimester biochemistry, where whenever we give a biochemistry sample, somehow they redate it based on the BPD value. And that changes by 5 days, 6 days, whatever at that stage, because we don't know what is the thing. So there again, we have to insist that please take the first trimester EDD as the EDD. Don't bother about the biometry in the second trimester again, because this is all labs are using BPD for dating for the quadruple test. Because that is not necessary. We can just stick to the first trimester EDD.
No, but then that you need to mention in your request itself.
TRF. We have to do it, sir. But what happens is we send the TRF. Somebody from the lab calls and asks the patient, please send a copy of your scan report. They send a copy of the scan report, and again, the dating is done with the BPD.
Very true, madam. Very practical point. Yes, we all face this problem, especially those SID labs, which, are...
No, even central labs are
SID. And, the problem is that collection centers have also created chaos. And each one of us should say, we will threaten you, we will not send you our next patient if you don't behave yourself. So we really have to be very firm with labs that they have to behave themselves. So we move on from our dating scan to our next scenario. And this is for Dr. T.R. Praveen. What are the clinical scenarios in which a scan is required at 14 to 17 weeks?
Basically, this is a new window that has been proposed, particularly by the Israeli group. Basically, this actually is early structural evaluation that has been proposed. So that even though you really try to evaluate most of the structural abnormalities right in the 11 to 14 weeks, or I mean 11 to 13 weeks, that is particularly 12 weeks plus, but still they would, it is better to reascertain certain abnormalities at least between, but the point is that there are certain evolving abnormalities which will actually evolve only after 20 weeks, which are again a difficult situation. So this 14 to 17 weeks scan basically gives us a window where we try to reascertain the structural normalcy of various structures, particularly the fetal brain and the fetal heart. These are the two areas where it has been extensively worked upon, and a lot of publications have been coming up in White Journal. So this is exactly what they put in. But then to us, most important thing, again, another important point which we have to realize here is that this 14 to 17 weeks is basically done transvaginally, and quite often you try to acquire volumes and then manipulate the volumes rather than just the grayscale imaging.
Wonderful. Now, in terms of some of the other suspicion areas, like if we had, say, a doubt in the 11 to 14 week scan, should we call them back in between at this window of 14 to 17, or should we wait until the anomaly scan? Or in case the patient wants to be reassured early, or say she doesn't want intervention in terms of invasive testing from an abnormal first trimester biochemistry or a quad test, are we justified in doing one?
No, but then how confident, what are our confidence levels in ascertaining whatever we found in the 11 to 13 or whatever was suspicious in 11 to 13. But then still, yes, it's a good window, which I think we have not been practicing, because quite often we used to get the patients at 18 to 20 weeks and most often 20 weeks. But then I think this one particular window, I think we should explore and try to understand, learn the basic criteria about this 11 to 14 weeks, because a lot of embryology has been demonstrated in this particular time.
Between 14 to 17 weeks.
Yes. 17 weeks.
Yeah. My next question is that
can we break for the trade?
We just go a little beyond this and then we move on to that break. Yeah, thanks. And this question was basically to take us forward on the rest of what we are seeing. And that is, Dr. Bimal, in the existing legal scenario, when should an anomaly scan be done? And in the new legal scenario, post the 2021 MTP Act, how do you think this should be done? Once the rules are drafted and released by the Ministry of Health and Family Welfare, which window should we shift to? Should we stick at the 18 to 20? Or should we go to a 20 to 22 or a 22 to 24 weeks?
At this moment, with the current rules, say the best time to do a mid-trimester anomaly scan is between 19 to 20 weeks.
Yeah.
So guidelines would say anytime after 18 weeks, but if you want me to be more precise, I would like to do it at 19 weeks, 3 days.
Yeah.
That I still have those 2-3 days for a quick fire QF-PCR or a FISH if required.
Yes.
I would prefer to do it at 19 weeks, 3 days. I'm very uncomfortable with this 18 to 19 weeks period.
Yes.
Because you see everything also and you don't see everything also. And what has happened is that in the last few years, the stress on markers and genetics and the testing has been so much that things have shifted from 19 to 20 to 18 weeks 1 day, because there should be sufficient time to do tests and all. See, I agree the genotype is very important, but in all these webinars or all these lectures that people have been hearing, they have been missing one very important point, which the geneticists have also been saying, and the fetal medicine people have also been saying, that it is, there is no genotype without a phenotype. So you can't rush after genotype at the cost of phenotype. So somewhere down the line, and then not everyone has very high-end machines where you can produce those wonderful images at 18 weeks or 18 weeks, 2 days. So 19 to 20 weeks at this moment should be the ideal time. And of course, like Praveen sir said, before that, it becomes a little tricky because it's what systems that we are. I think Indians are the best with this 19 to 20 weeks period, because for years we have been constantly working on that particular period.
No, my question is, why can't we do it at 20 to 22 now with the legislation which has been
No,
changed?
sir, that is the second part of the question, sir.
Oh,
The first part was as of today, sir.
As of today also, isn't it? As of today also, the legal implications have.
Sir, we are talking about screening for anomalies in general, sir.
Yeah.
Yeah, in general,
low risk group, yes.
We don't want to put it. So I would say, and secondly, if a well done 11 to 14 week scan, then again, I feel we need not rush at the 18 weeks. So directly 19 to 20 weeks as of today. Yeah. As far as the second part of your question, which is after this new, we really don't know the rules in detail, sir. If it is like, if the 20 weeks has shifted perfectly like it is today to 24 weeks, then I would like to do it at around 22 weeks of gestation. But if not, then we still stick to the 19 to 20 weeks as the primary screening for the anomalies, and then we have the second window available at 22 to 23 weeks.
I'm sure that,
especially in the high-risk pregnancies, I would still like to do it at the 19 to 20 weeks.
I think SFM and Ashok has put in a lot of effort to get this legislation done. I think we should trust him at least.
So we are very optimistic about it, sir. We're very optimistic about it. So in India, till the times things don't come on paper officially, we don't know what changes still happen into that, sir.
No, don't worry. We are very much in the paper scene also, because SFM has its representatives on the rules committee, and they're sitting in and they've written them out. They just have to get them approved now. And then I know that since we really see much better at 20 or 22 weeks, we will happily shift that window there, but we'll just wait for the rules to be declared. But I promise you, we're not letting them hijack this agenda this time, that we will see that we will read every single rule before it gets put into any sort of official notification.
But high-risk pregnancies?
High-risk we will put still at 19.
One scan before,
and routine low risk, which we do for the whole population, we can shift to between 20 and 22, because then we have unlimited time to really think, and we have a much better genotype, let's face it, at 20 or 22 weeks. Our hearts are seen much better. And with the kind of metabolism, I'm sure you'll all agree with me, our basic BMI is now jumping and jumping and jumping. So it's really very comfortable to do an 11 to 14 scan and then as close to the umbilicus as possible, because in between then we have this gorgeous terrain that even tanks of the armored corps can't see anything through.
But there is another side to this also, that once we start doing these scans at 22 weeks, our responsibility will be much more than what it was before.
That is true.
Number of excuses will be much, you can't give too much of excuses as regards, okay, we know the CSP is not well formed by 18 weeks and all that. 22 weeks, expectations will be higher from your end.
Yes, and this is why I keep putting this chart up each time, that if we were doing our scans at 18 weeks, we were actually picking up only about 60%. And if I do them at 23 weeks, I'm pretty much picking up 80% of my abnormalities, which is really so much nicer to do. So we are hoping that these rules will come in as soon as possible. Thanks to COVID, we were able to push through because people were free to do things on Zoom. So initially we thought we'll get stuck, but Zoom is helping, and so we'll have some good news. And before
can I make a point on this?
Yes, of course.
Reality check on what is happening.
Yeah.
Every month we are getting patients who are diagnosed at 18, 19 or later on, and by the time they reach a fetal medicine specialist or to a tertiary center, they are already 21, 22 weeks of gestation. So yes, the bigger the baby, the better we can see. The poorer the resolution machine, again we want a bigger baby to see. Obesity, again we want umbilicus area. And also that by the time they reach a tertiary center, they are already 21, 22 weeks. So whenever this MTP Act comes into being, then maybe that 20 to 22 weeks is again the time, and not a little late, because again the patient will reach us at 24 and become more late. And by that time, I think the ribs and the ossifications will increase, and the window will be less at that moment of time. At
Yeah.
least every month, I am sending some legal terminations to the court and getting them done in Bombay. So even in a place like Maharashtra and in Mumbai, we are getting so many cases which we are terminating at 26, 28 weeks because they come to us late.
Yeah. So what we do is to say, okay, mid-trimester normally scan at 20 weeks, because that will give us enough time to work on, the 20 can shift to 21, or you might have to wait a week for an appointment and things like that. So like that. And our last question before the break, Dr. Vaishali, when a mid-trimester anomaly scan does not match up to our quality standards, when should we repeat it? Immediately or later?
I think my question has been already answered by the expertise, but I just want to add on few things that because of maternal habitus and equipment considerations, if your first mid-trimester scan is not optimum, then you can directly refer the patient to the expertise with an proper equipment. Or the second option is, if you want to repeat the scan, you can repeat it after 2 to 3 weeks, provided this should be noted on the document, on the medical records. In the great study which was done by Handler and at a huge number of mothers, it showed that repeated ultrasound examinations for suboptimal visualization of fetal heart dramatically reduces the suboptimal visualization, diagnosing many of the normal fetal hearts and few of the abnormalities. So when we see that the first anomaly scan is suboptimal, we have to consider for a few areas where we have to put a lot of attention. These are cardiac defects, craniospinal defects, and a few other defects where the fluid is less and we have to re-see it again due to some technical errors.
Wonderful.
So can we give a message saying that, yes, it can be repeated? If you have a suboptimal anomaly scan, mid-trimester anomaly scan, I think it is earlier the better you repeat it and re-evaluate, reascertain the normalcy or abnormality, because this message has to be very clear. I mean, no ambiguity.
So we would therefore say in our reports that it was suboptimal because of this particular reason. And if that reason is maternal habitus, then we would say, okay, we give it a delay and hope that we see better after a few weeks. But otherwise, we would like to reschedule it. Yeah, if it's either because of lack of expertise, etc., then we really should do it as soon as possible. In fact, I don't know whether Bimal agrees with me on this. You could call back the patient later in the day or next morning just to get the right view. Bimal, would you agree with that?
Sir, I'm very, I would say, non-popular because of the time frame that I require for doing anomaly scan, the mid-trimester anomaly scans, because usually most of the patients with bad sonopenetration land up at my clinic. So there is definitely, there should be no time criteria for, no law is telling us that, okay, once the patient is on your table, you have to finish the scan and get up. So you have your checklist, you go by your checklist, you're not seeing it, let the patient have a coffee, come back. If still or chocolate they can have and come back after some time. If not, call them again in the evening. You have a very busy OPD, let them go back home, let them come back again. Still you're not able to make out, then again next day. In spite of all that, then document. See, I think Vaishali has brought out a very important point that even if you're seeking a second opinion, a lot of people feel that a second opinion is an expert opinion. Not necessary. If you can ask for an expert opinion also, but you're seeking a second opinion or you're calling for a follow-up for suboptimal evaluation, then it should be documented very, very clearly. If you just say orally that, yes, you go and get one more done, that does not suffice. It should be. And
or even a corroboration of the fact that sonopenetration is bad. There are some women who've had bariatric surgeries or who've had that liposuctions and things like that. And whatever you do, you will not be able to penetrate that barrier through whichever probe you want. So in first trimester, we have the transvaginal window. In second trimester, that is not always possible. So if you don't get it and it just makes the patient feel better to go and hear it from another person, good for you. I mean, it's always good for just documenting that, look, this is the reason we are not getting it. And it's not, we can always stand by our colleagues and say, look, this is how it's seen. So there's no harm that what the other person could not see. Maybe it's not always a failure.
Maybe 2 weeks down the line, things may not improve also. So
Yes,
my,
true.
my statement is that suggested an opinion, suggested a follow-up scan after 2 to 3 weeks for a possible better visualization of
Absolutely.
fetal anatomy.
Excellent, excellent.
Yeah,
Yes.
you can't probably, after 3 weeks down the line, things are not really going to make a huge difference, maybe a little better.
And what helps sometimes, sir, is we show them, because sometimes they're very disappointed. They come from that Google search of those beautiful images. And then when they see that, oh, why can't I see my baby like that? So, it sometimes helps us to just go back in the archive and show them, look, this is how a baby can look on this machine. But we need all the factors falling in place. So because it's not falling in place, otherwise they will think, okay, you can't get a good image for them. So we can get good images, but right now all the factors are not in our favor. So that's okay. We'll try again. If it works, it works. If not, then we'll go by the standard basic checklist.
We also document at the end that the limitations of the scan because of poor sonographic penetration has been explained to the patient. That is something we document and take a signature from them also.
It's a very good idea. Yeah.
We tell them that, yes, I tell them right in the beginning, see, I'm going to have a lot of limitations. The scan is going to be suboptimal, but I'm going to give my best possible, but the limitations are still going to remain. You will have to accept that. That is something you explain to them, then it becomes easy and you can put it on paper also and take their signature. It is always a good practice to do that.
Excellent. We'll stop my screen and go on to some messages from our trade partners, and we come back in the next few minutes. And so here we're back again. I just wanted to check if you can all see my slides. Yes, wonderful. So we have now our next 10, which are questions that are completely less controversial, because we seem to be far more comfortable in that zone in what we've been discussing over the past few months. So let's start with 2 case scenarios first. And Dr. Vandana Bansal, if a nasal bone is not seen at 11 weeks, 5 days, there seems to be a tendency to call the patient back rather than doing anything else. What is your opinion on this?
First trimester absent nasal bone is a strong marker for Down syndrome. So although we know in Asian population, the chances of ossification is a little late. And so maybe people would do a repeat scan and see for nasal bone in the later gestation. But it's a very strong marker with a likelihood ratio of 6, what is there in the literature. So I would not wait for a nasal bone to ossify and then change our aneuploidy risk stratification. I would take this as an absent nasal bone at 11+5. It's the right time to have seen a nasal bone. And I would give them option of doing an invasive testing and looking at it at 100%, or maybe look at NIPT. But I would, my choice would be to do a CVS, look at aneuploidy screening, aneuploidy detection at this moment of time. Yes, we can look at nasal bone later on, but I would still do a test in the first trimester, do a CVS, know that it's chromosomally normal, and maybe at an anomaly scan again look at whether the nasal bone has come or not.
Excellent,
Anyway,
thank you.
check the facial deformity, so I would just reassure if the aneuploidy testing, invasive testing is normal.
Excellent. Thank you so much for that. And the next case scenario, Dr. T.L. Praveen, if the cavum septum pellucidum is not defined adequately at 18 to 19 weeks, when should we review it? And what would be the elements of counseling in this scenario?
Right. I mean, first and foremost thing, all of us should very clearly understand that all the 3 axial views, that is transventricular, transthalamic, as well as transcerebral, should demonstrate cavum septum pellucidum. But the caveat is that you need to understand that at about 18 weeks of gestation, sometimes you may not be able to properly demonstrate the cavum septum pellucidum. Similarly, when the fetus is about 36 to 37 weeks, again, the cavum septum pellucidum may not be seen properly. So these are the 2 limitations or extreme limitations that we have to keep in mind while evaluating cavum septum pellucidum. Now, not only seeing the cavum septum pellucidum, the size of the cavum septum pellucidum, the shape of the cavum septum pellucidum have to be considered. Now, when we have a situation like a clinical scenario where we have a fetus about 18 weeks, with the cavum septum pellucidum which is not seen or not defined, In that situation, I would definitely not hurry up and label them as absent cavum septum pellucidum and try to, put them into anxiety. But then I would definitely ask them to come back at about 20 weeks of gestation so that I'll be much more sure. Not only that, I'll be much more sure whether the cavum septum is present or absent, but also I would be able to do further investigation in the form of neurosonography, particularly to use the transvaginal approach if the fetus is in head presentation or cephalic presentation, and try to get the kernel section as well as the sagittal section in order to really thoroughly evaluate the cavum septum pellucidum.
Thank you. Thank you so much for that wonderful advice on how best to follow this up in terms of timing the scan. And we move on to our next question. Dr. Vimal Sane, what is the ideal time slot for a fetal echocardiography? When should a repeat be done? Do we differentiate between low risk versus high risk and so on? What is your opinion on all of this?
Yes, sir. We do need to distinguish between low risk and high risk. Of course, low risk, we start right from the 11 to 14 week scan. We do a transvaginal and try to take a good look at the heart with both grayscale and color and axis, and look for any pointers which do suggest. But otherwise, I would, the guidelines, of course, say that anytime between 18 to 24 weeks, you can do a fetal echocardiography. But there has been a trend in our country where the fetal echo is pushed to 20 to 23 weeks. But I feel a good fetal echo can be done at at the time when you're doing your mid-trimester anomaly scan, and that is at the 19 to 20 weeks. You can do a good fetal echocardiography. And of course, if there are limitations or there are subtle findings, the next thing definitely, yes, look at the heart at around 23 weeks is far better than what you see at 19 to 20 weeks. It also depends a lot on what is the kind of machine you have, your color settings. If you're using a high-end machine, definitely a 19 to 20 weeks fetal echo is good enough.
Wonderful. Thank you for that. And we move on to our next question. And this is for Dr. Vaishali. Beyond the 24 weeks mark, is there a role for an anomalies review based on ultrasound findings at 20 weeks, or in the situation where there is a previous history or a clinical finding such as polyamnios? What is this embryological timetable that is often discussed?
We all have been hearing about inverted pyramid of care. For a change, let us focus on USG diagnosed abnormalities in the third trimester, because we don't want to end up with some ugly surprises. So we need to know if after 24 weeks marks, is there any importance of USG in the third trimester? So there are structural defects which we can diagnose in first trimester, almost 40% of them. Add on to that in the second trimester by 35%, and in the third trimester, 15% of the structural defects can be identified. We must see there should be a checklist. As there is a checklist for second trimester ultrasound scan, there is also a checklist for third trimester ultrasound scan, like in skull, head, brain, stomach, GIT, diaphragm, kidneys, and transverse view of spine at least. So what we cannot see in the third trimester is extremities and the tip of the spine. And what you could see, it depends on the position of the baby, is face, heart, and the spine. So actually, these are three kinds of defects which we can see in the third trimester. Those are like, first, we actually missed it. It was there at the anomaly scan, but we missed it. We could not pick it up. Second, it progressed like agenesis of corpus callosum. It was there, but we could visualize it properly in the third trimester. And ventriculomegaly, which was almost 10 millimeters or mild, which progressed later on. And the third ones are evolving defects, which could not have been seen at anomaly scan because they evolved later. And these are microcephaly and absence of stomach bubble and polyhydramnios. In case of absence of stomach bubble, we should check, wait for 15-20 minutes. We can recall the mother after some time, and mostly it will be mostly always there. So check for the amniotic fluid. Here we have few pointers, like in case of oligohydramnios, we can see that we can ask the mother the history about the leak. If mother is giving a clear history about the leakage, we know that there is no swallowing of amniotic fluid. That's why the stomach bubble is absent. In case of polyhydramnios or increased amniotic fluid, we should be very careful here to say that it is not because of maternal diabetes and it is because of some structural defect. So first of all, what we write on the report is evaluate the maternal sugar levels. And if on evaluation, the maternal sugars are also normal, still we write on the report that this can be because of some tracheoesophageal fistulas where, or some bowel atrasias where the fluid is increased because of less swallowing. And we have to look for these defects on the ultrasound. So we have to write clearly in the report that not all kinds of tracheoesophageal fistulas can be diagnosed antenatally, and especially those which are very common will show a stomach on ultrasound scan. Now we come back to bowel atrasias. Most of the bowel atrasias are associated with aneuploidies, in particular trisomy 21. So if we know that there is a polyhydramnios, there is enlarged bowel, and but the karyotype is normal, we can assure the couple that at least the prognosis of this pregnancy after surgeries is good. So holistic approach should be there to look for bowel, look for abdominal cysts, where you can actually categorize the cyst according to the quadrants, like right upper quadrant, left upper quadrant, posterior, anterior, and lower abdominal cyst. So depending upon the site and association of the cyst, you can give the diagnosis and differential diagnosis as well. Look for polyhydram when there is a polyhydramness and your first trimester anomaly scan is normal. However, you can see that there is no stomach in the abdomen. Look for the stomach in the chest. Maybe you are missing a diaphragmatic hernia. So there are few CNS abnormalities where microcephaly and other neuronal migration disorders can be diagnosed in the third trimester. Renal system anomalies can also be diagnosed in the third trimester, and achondroplasia is very the abnormality which can be only diagnosed after 24 weeks or 24 to 26 weeks. So fetal defects in the third trimester, especially you should look for GIT, GUT, heart defects, and CNS defect. So planning and timing of delivery, counseling regarding postnatal plan and the management, outcomes and financing should be discussed with the couple after doing a third trimester scan. And here you can let them make an informed decision, because a baby with a bad prognosis, will you really protect preterm birth?
Thank you. So what I was actually also wanting to emphasize was that there would be certain situations where because of a previous history, we say, okay, the patient is very keen to know, do I have a tonal atresia, for instance? And I said, no, well, we could still miss it at the time of the anomaly scan. So we will schedule one for about 24 to 26 weeks. And then the same thing could apply to urological conditions. And then, of course, for cardiac evaluation. So we may not just wait late into the third trimester, but certainly closer to 26 or 28 weeks. And then we would consider that definitely. Vimal, yes?
All patients showing us liker abnormalities either way in the second trimester. And if you are not able to pinpoint the cause at that time, is definitely a clear indication for a scan at around, as you rightly pointed out, not going too late, but definitely at between 24 to 26 weeks, because we know most of these GI obstructions are going to manifest, you'll be able to pick them up later. Yes. Even with your esophageal this thing, and we all talk about the esophageal pouch and the dilated hypopharynx. These are all things which you're going to see at around 26 weeks.
Yeah. Thanks so much for that. And we move on to our next question, Dr. Chinmay. Scan for everyone at 36 weeks. Your opinion, please, and not just for anomalies, but for everything else.
For the last 4 to 5 years, from the time that we've started acknowledging the presence of this entity called late onset IUGR and the potential for damage with a late onset IUGR being not picked up. In our unit, yes, it is a routine sort of advice to every pregnant woman that we should have a scan 36 weeks. When we are following up pregnancies for various complications, of course, that becomes a unique indication that holds true. But if you're asking for a universal scan at 36 weeks for everybody, my personal opinion is yes. I do agree that there are problems with resource allocation and other issues why people would be wary of giving this kind of advice. But then again, what is the trade-off? When we are not doing a late scan, we are failing to pick up that group of patients who would benefit by an offer of delivery at 37 weeks. I'm not saying cesarean section at 7 weeks. I'm just saying an offer of delivery, because suppose this woman is setting into late onset IUGR and has the very, very subtle Doppler changes, what we have now learned to appreciate in these cases, then we know that this is a woman who would benefit from induction of labor, or at least a trial of, um, effecting delivery by 37 to 38 weeks. We would not let this woman go on till 40 weeks and wait for the spontaneous onset of labor, by which time there might be a lot of damage with respect to hypoxia and even acidosis happening inside, which would otherwise go undetected. There is also a risk of stillbirth. So doing this 36-week scan helps us in differentiating that group which needs an early delivery and the group which we can leave happily for whatever traditional obstetrics was expected to be, that they will keep coming for their regular weekly checkups and then, set into labor one day and come to labor ward and deliver happily. So checking at 36 weeks, yes. Specific indications when you have a placenta previa, or you have a previous cesarean section with pain in abdomen, or you're on a follow-up for something, those are of course specific indications. But for everybody, yes, growth and Doppler also at 36 weeks, so that you look for middle cerebral artery PI as well as the umbilical artery PI at that stage.
Excellent. Thanks so much. And that takes us to a radiological answer to that question. Dr. Thiran Praveen, please give us a checklist for a scan 36 weeks.
I think Vaishali has really covered the whole topic about third trimester. That is Now, I think we are presently going to be with the 36-week scan. Now, basically, if I'm asked to do 3 scans, one I would pick up at about 12 weeks of gestation, the second one at about 22 weeks of gestation, and the third one at about 36 weeks of gestation. This one will be not only for the growth and Dopplers, but also for late onset anomalies. And at the same time, fetal atmosphere is one of the most important things. As we all know, the placental changes, amniotic changes, and the umbilical cord changes can be looked at this particular stage. But then, not only that, the biophysical activity of the fetus also can be evaluated to some extent, which can also contribute to in decision making in these patients, where we need to take calls whether to deliver them prematurity or continuing the pregnancy and resulting in stillbirth. So these are the things that definitely one has to do at 36 weeks scan. The checklist, basically, if I am asked to, a regular thorough second trimester anomaly scan protocol will be followed for the anomalies in the third trimester. I will look carefully about the fetal atmosphere, the amount of amniotic fluid, as well as the placenta. And then the fetal growth, anyway, we are going to assess. At the same time, we will try to evaluate the hemodynamics, and along with it, to some extent, the biophysical profile. So this is how I would approach as a radiologist dealing with the fetus at 36 weeks of gestation.
And of course, there would be those odd ones where you suddenly find a half kilo dermoid or fibroid sitting right there in the middle, and you say, oh, thank God we found it, and a malpresentation that might need to be followed up. So we would then move on to a very, very important question, which actually has 3 parts. The third part is really something that I wish to emphasize today, and that's what we will talk about. Dr. Vandana Bansal, growth scans at 28 to 32 weeks, or should we just say 30 weeks? With the high incidence of growth restriction and nutritional small for gestational age, should we encourage this in affording patients? And should every growth scan include a multi-vessel Doppler?
So let us the first part of the question, whether we do a scan between 28 to 32 weeks. You've said it is in affording patients. Definitely we need to do, because it is this time that we can pick up the centiles which have started dropping down. We would look at the Leica as well as do all the Dopplers. So it cannot be a growth scan which is without a Doppler. A growth scan has to be with a Doppler now. The guidelines are old, and I think the guidelines need to be changed, that if the growth is normal, you don't need a Doppler. Especially as what Chinmay said, late onset uh, growth restriction, you will not have a significant growth restriction. There'll be no preeclampsia, there'll be no clinical findings on obstetric maternal testing. So it will only be on these subtle Doppler changes, the middle cerebral artery brain sparing, the CPR which has changed, is what we are going to pick up. So when we were only looking at umbilical artery Dopplers, we were looking at early onset IUGR. So there it was a different thing, that if the growth is normal, we can just not do a Doppler. But now definitely if we are going to do a scan at 30, 32 weeks, it has to be with a Doppler, and Doppler of uterine artery also, along with umbilical middle cerebral artery to be seen. Uterine is also important. Earlier we were saying that it is only for predicting preeclampsia and IUGR at your 18 weeks. But now it is part of the definition for growth restriction, that if the growth is less than 10 centile, uterine artery PI is one of the marker to say that yes, it is FGR and not a small for gestational constitutional small. So Doppler is definitely required. There, I don't think there is a question. The guidelines need to change. And yes, for affording, I do a 30 to 32 week scan. But if it has to be just one scan, maybe 36, 35, 36 weeks is when I would want to do. But this is a time when I can tell the patient to eat better, start looking at monitoring more better. If it is really bad, then I want to transfer her to a center which has got better facilities. If I see some anomalies, I can get them to meet a pediatrician, decide the time of delivery, decide the mode of delivery. So all these things we have some time to work on. So ideally, yes, I would do a scan at 30 to 32 weeks, both for anomalies, because 25% of anomalies are picked up late, and in an India-like position where we don't have, we have suboptimal ultrasounds, we may pick up something which is missed, and we need to have our obstetrician, pediatrician, the center where we want to manage them, all done together for the patient, for better facilities for the child which comes out.
Thank you. Thank you for putting it so beautifully. Inputs from Dr. Chinmay on this, please.
Yes, sir. I think Dr. Vandana has already summarized it very well. If a patient is able to afford that, and it's like affordability is not a huge issue, then after we have seen them in the anomaly scan at 19, 20 weeks, waiting till 36 is a long time for us. So we definitely would like to call them at 28 to 30 weeks and do a first, what we call as a baseline growth scan. And earlier we were happy with that only 4-5 years back. If that was normal, we actually left it on them. If they didn't want to come for another scan, we would leave it on them, because we would trust the obstetrician to do regular, gravidograms and see that the fundal height is growing as it was. But then once we've understood the importance of the late IUGR, if I have to choose just one scan, probably 34 to 36 weeks. But if you give me the luxury of doing 2 scans, then one at 28 to 30 weeks and one at 34 to 36 weeks.
Excellent. Thank you. Would anybody on the panel disagree with that?
Why should we disagree?
Don't you dare. Thank you.
Sir, since we talk so much about the number of scans for detecting anomalies,
yes,
and then you said right in the beginning of this that the prevalence of FGR and SGA is far more than all these things put together.
Sure.
I think this 30-week scan actually sets the tone for detecting our growth abnormalities. It gives us the platform to decide on how we would like to do surveillance in this particular fetus. And of course, the luxury of affordability comes into picture. But then if all these affordability, we talk about aneuploidy screening and for anomalies and for all those, for something which has such a high preference, I think the affordability should come into if you explain it to them, people will always.
Should not be an issue.
Agreed, sir. I think that awareness is the most important
Yes.
thing, because for every scan, if we are able to avoid a risk of prematurity or a risk of inappropriate outcome of that pregnancy, then the cost is really not that much.
Yeah.
And
Absolutely.
I feel adding of Dopplers won't take much time. It hardly takes few minutes to add, but it gives a very important information upon the growth scan. Most of the times I have seen that I got the referrals only for growth, only for AFI. Why this only for? This doesn't add much of your efforts and much of your money to expenses too, but it gives a very, very great information.
I think that's an important point, Vaishali, and I think we should agree that we are not going to do growth scans unless we do the Doppler
Definitely.
along with it, because it's half information.
I think we should make it very clear that growth scan includes Dopplers.
Dopplers.
There is
Yes.
no ambiguity about that, because that I think we should make it very clear. Whether they ask, they don't ask, it doesn't make sense.
There is nothing
A
called.
growth scan by definition is a Doppler scan included,
Yes.
and you don't differentiate between the two.
Yes.
There is nothing.
The
Yeah.
cost should remain the same between a growth and a Doppler, because then
Yeah.
only the obstetrician will accept that yes, we need to do a Doppler along with that.
There is nothing called routine scan.
Yes.
And I think that indication number 18 should go away. The indication number 17 should remain. That is for fetal well-being. Now, when it comes for fetal well-being, everything comes in a package. There is nothing called a routine scan or just see the liker. Yes, these are things which are not acceptable.
But I find off late, even the obstetricians have stopped asking this sort of requests. I mean, they're not asking only like, I don't know, I mean, in our practice, I don't find them asking that sort of request.
So maybe you work in a very right area, or where there is understanding about growth
Possible.
and Doppler.
Possible.
But however, here in the scenario is very different. They only will ask you for AFI, and the mother is coming for the first time to you with the only prescription of AFI. What I'm supposed to see in her?
So
All
just
those-
measure and say AFI 15.1.
All those options.
So, Vaishali, I think that would be the failure not of science, but failure on the part of the Society of Fetal Medicine to not educate enough of our obstetricians.
We need to educate them.
We really must spread this message very clearly.
Yes.
And I would encourage you to work together with everybody in your area, or just spearhead something so that we make sure that the way we've evolved things in some of the smaller towns now.
I think even in the initial stages, we did find this sort of a request, but then as we spoke to the obstetrician saying that AFI alone will not answer, and we are not going to charge anything extra for doing a growth scan as well as a Doppler.
That is important.
So that once that is said, I think they are comfortable. As long as money is concerned, once you say the money is not extra, and they are very comfortable.
Yes, and we also have to straighten out the national perspective, which firmly believes that this cost is the cost of an ultrasound. It is the cost of neurodevelopment for the next 100 years for that individual.
Definitely.
It's the cost of nursery care as soon as that baby is born. And it is the cost of bringing up an individual with a disability that could have been avoided. So that long-term perspective, we have to get our government to straighten out. We've started working with that at the Society of Fetal Medicine. A lot of us, Dr. Parna Sharma, me, are sitting in the Ministry of Health and Family Welfare for hours on end, trying to push this point home. And I think with all of us joining in at the state level, we should be able to achieve this. So we agree that every growth scan should be a Doppler scan. We agree that there should not be any partial scans, and it does not make any logical sense.
All those who have attended even 20% of the webinars of SFM in the last 1 year have stopped asking for routine growth scans.
That is true. They presume it will be a Doppler scan. They'll be very disappointed if the Doppler is not there. Yes.
Can I add to this? Are we absolved of any medical legal responsibilities when we do a growth scan and not look at the structure? So
I think very, as you told us, Dr. Bansal, there is this very straightforward thing that you try an artery Doppler, and the Doppler is part of the definition. So I would be guilty if I did not mention a Doppler report in my biometry. A biometry by itself is absolutely nonsensical in today's day and age. So I would never be able to support someone.
Yeah, basically, when you are talking about 30 plus, you are talking about not only the nutrition, but also the oxygenation, wherein unless that is evaluated by doing a Doppler, it doesn't make any sense just doing the size of the baby.
Yes, absolutely. And so our last question for the evening before we move on to our participants' questions. Dr. Vandana Bansal, could you please tell us a standard protocol for twins? I'm going to put one up from the guidelines, but please feel free to modify this as you think appropriate.
So first of all, we are doing our first 11 to 14 week scan, which is necessary for all twins and for all singletons. So here what we are looking at is mainly for dating, but we also look at chorionicity, which is the extreme important thing that is required in twin pregnancy. We would also label these fetuses at this moment of time because we need to monitor them for growth later on. And at the same time also look for screening and for aneuploidy screening. Also maybe look at the cervix and look at uterine artery Dopplers, which may not have so much of importance than other things. But 11 to 14 weeks is the scan to be done for both. Then when we are looking at low risk population of twin pregnancy, then for DCDA, we can follow them up for the anomaly scan at our 18 to 20 weeks or 20 to 22 for Indian population. I think 18 to 20 at the moment when we look at the anomalies. At this time, cervical length is extremely important because if it is shortening less than 2.5, we might think of progesterone or put a cerclage. And at this time, look at the discrepancies in the Likert as well as biometry. And then we follow them up 4 weekly. So for a low risk DCDA twins, no hypertension, growths have been normal. We monitor them by 4 weekly scans, and scan would mean growth, Likert, Doppler important, and that's how we follow them up. And DCDA twins we would deliver at around 38 weeks if everything goes on fine. But if it is a monochorionic twins, we need to start monitoring them little early. So once we know at 11 to 14 weeks that it's a MCDA twins and we've done the aneuploidy screening, then we start monitoring them from 16 weeks. This is basically for TTTS that we are looking at. So we follow them up for growth, Likert discrepancy, the bladder discrepancy, and also look at umbilical artery PI, and also later on for MCA PSV. So basically we are looking at TTTS and TAPS. So here we follow up every 2 weekly, and so at 16 and then 18 and then every 2 week is what we follow till we reach about, for MCDA we want to deliver by 36 to 37 weeks, and for MCMA for between 34 to 36 weeks. For MCMA we would want to continue to monitor a little more, and we look at cord entanglement, which is part of all MCMA fetuses. But once we see anywhere the growth discordancy, then we need to follow DCDA maybe more frequently 2 weekly, and MCMA maybe every weekly. So it depends on, if I start seeing growth discordancy, then I start monitoring them more strictly. Otherwise, DCDA is 4 weekly and MCDA is 2 weekly. Follow up every cervix also.
Thank you, and that should be absolutely no room for doubt.
Sir, I will add something more to this is because sometimes you don't get mothers at 11 to 14 weeks, twin mothers. So what suddenly you get a pregnancy at 20 weeks and you know that both the babies are having anterior placenta, wherein you have lost that window like before 16 weeks as we see the lambda sign. So you have lost that window to properly say that it is dichorionic or monochorionic pregnancy. In such scenarios, we should consider it as monochorionic twin pregnancy and follow it like that only.
That's almost, yeah.
Sure enough, yes. So that, thank you very much to the panel for putting all this in such excellent perspective. And that takes me to the questions. And only then will I thank everyone, because we have a chat box that is not very full. We've answered a lot of these as we've gone along, but I'm still going to reiterate some of our messages as we go along. So my request to the panel to please stay on for another 10-15 minutes. And Samish Gupta wants to make sure about this business of EDD changes in every ultrasound scan. Up to which trimester can we give EDD in written report? So may I, on behalf of the panel, say very clearly that the EDD is fixed in the first trimester and we don't change the EDD. We don't need to re-mention the EDD that we had fixed originally in every report. That remains fixed and is on record. And we certainly will not write any new EDD on any report. Any discrepancy on this? Is everybody agreed with me on this?
No.
Excellent. And so this message was reinforced by Dr. Jyotsna Rani, who is on our executive committee, as you know. And then there was a question on the fact that for twin fetuses, can we write 2 different EDDs? And Dr. Answered that very clearly, that we will go by the larger fetus because we don't expect the smaller fetus to be the representative. We don't expect macrosomia at that stage. Now, there's one very interesting question from Dr. Sumati Natarajan, and she says, what weeks should we write in the impression, the composite age given by the machine or the LMP gestational age and growth scan reports? I do hope that this question was asked before we discuss this in detail, that we will not be mentioning the composite age and we will be mentioning the EDD gestational age as calculated from our original calculations. And we will be able to do all our machines. Every single machine can be programmed according to our calculated EDD. Then, of course, for twins, we like to reinforce that the EDD assigned as the first trimester scan should be considered, and of course, by the larger one. And then there was a great appreciation from Dr. Yashodhara Gaur and others for Dr. Chinmay's insight into getting the machine program correctly, which is the simplest thing to do. And the question then is, from Dr. Beena Mishra again, she feels that we should date at 8 weeks. And what is your opinion? So could we have re-input on this? Dating scan should be done at 8 weeks. What is your opinion? Dr. Thieren Praveen, what do you think?
I mean, I don't mind doing a scan at 8 weeks, but I would be a little skeptical in using that parameter CRL in deciding the expected date of delivery. Because quite often at 8 weeks, you may have a C-shaped embryo, which may not give you an entire length of the embryo. That is one. Second important thing is the charts that have been designed are basically designed between 45 to 84 weeks. So millimeters. So, to date the pregnancy based on 8 week scan is little tricky. And I would definitely re-emphasize by doing a 11 to 13 week scan.
Wonderful. Yes, please. Yeah.
While I was looking into literature, I saw that ACOG has got a new guideline which is talking about 7 to 9 weeks when you can see within plus minus 5 days, and your 11 to 13 plus 4 weeks is for your 7 days discrepancy. So actually what they're talking about is the discrepancy is less in the first trimester. So this 7 to 9 weeks is a good time for dating pregnancy rather than the 11 to 14 weeks, because the fetus has flexions and other things to be seen. So it has come in the ACO committee opinion on
that is again assuming that the CRL has been taken absolutely correctly. What Praveen has said is a practical issue, because many times obstetricians do the first trimester scan themselves, and we have a very small picture there and some measurement there, and sometimes there is a difference of almost 4 or 5 days, and that leads to problems. Whereas in the second this 11 to 14 weeks period, it is mandatory to have a full picture of that fetus in a neutral position, which is better documented. So there's no harm in doing it in 8 weeks, but always reconfirm it at the 11 to 12 weeks. If there is a discrepancy, maybe stick to the 11 to 12 weeks.
Correct. And we are not able to identify markers at so early gestation. So at NT scan, if we see that there is increased NT, we will not redate that pregnancy. That's why this redating, with again and again redating the pregnancy, will be avoided.
Wonderful.
Practically, sir, 9 to 10 weeks is
actually... But then we can't call the patient so many times, isn't it? So
that's what I'm saying.
In all practical purposes, the patient comes to the obstetrician within a week or 2 of her pregnancy test being positive in a routine case. So a couple of days after that, we do a scan to make sure that there is an intrauterine pregnancy, to rule out multiple pregnancies, and to make sure that there is a viable pregnancy inside.
Absolutely.
If we can date it well and good, but whenever we date it, we actually tell them that, look, we have put the dates as to what it's appearing now, but when we'll see you at the NT scan, we'll confirm your dates at that time. So the patient also knows that the dates are going to be reconfirmed at the 11 to 14 weeks, so that, they are not surprised if the date changes.
Wonderful, which also answers our next question from Dr. Indu Sharma, which is, how will we date the pregnancy with a FGR fetus first time in late second or third trimester? So it is the same thing, that we really have to look at all the things we discussed, pull out her old reports, see how reliable those images are. And both our speakers, Dr. Bimal Sani and Dr. T.L. Praveen, said this, that we really must depend on all our sources and then go ahead. Otherwise, we always have the option of serial evaluation. Then there was, of course, the message from Dr. Rekha Maratha, who said that, look, for a quad test, the lab people keep on making so much noise, but we have to sit on the head and say, you will learn to behave yourself. Otherwise, we will make sure that your lab gets shut down and de-recognized by the Society of Fetal Medicine. I think we have to start taking stern steps. Dr. Ratnapuri is already working on laboratory guidelines, and she is going to form a committee soon, so that then we will be able to throw this at them. And then, of course, Dr. Shubhangi Mundada had said that, look, if there is a previous anomalous baby, it would be a good idea to do a 14 to 17 week scan, which Dr. T.L. Praveen brought out so beautifully. Now, there is this question of missing an anomaly. It's not related to our discussion today, but if you miss an anomaly in a patient with BMI, in spite of repeated examination, is it legally justified? I think we've answered this question, that as long as we keep mentioning it in the report, that our visualization was limited by patient habitus, and this limited the examination, then it's very straightforward that we cannot then be held liable for this kind of a thing, that we made the effort. And this is exactly what the law says, that if they find negligence, then it is this. But if we clearly say that we tried, then it is no longer negligence.
We also write down at times the number of attempts we have done.
Yeah.
I see. That's an excellent idea. That's
Plus, major abnormalities won't be missed, sir. If we see the babies with these guidelines and all, major abnormalities won't be missed. What will be missed will be polydactyly, syndactyly, and other few abnormalities.
No, we see a lot of missing limbs, for instance. We don't know whether it was because
you
it was
cannot be that confident saying that you will never miss him, and there is always a human.
Yeah. Yes. And then there's a very important question here which we must clarify, and this is from Kirti Nahar. She says that in the 11 to 14 week scan, we have a CRL, but most of us have also now started doing a head circumference, an abdominal circumference, and a femur length.
That's a wonderful practice.
Should we take it and we compare it in the future, but should we then base our gestational age on just the CRL or a composite?
No, CRL.
Excellent. So the answer is absolutely.
The reason why we do all this BPD head circumference as well as the abdominal circumference is to evaluate all those structures. It
Yes.
makes you see them. That is the idea why we measure them.
Yeah.
And the only important point here is that there should not be a BPD, HC, FL, humerus, tibia, radius ulna, everything, and no CRL.
Very, very important.
Yeah, I see quite a lot of reports where they've given the complete gamut of the biometry at 12, 13 weeks, and there's no CRL. And the lab has accepted that also and has given the risk also. I don't know how they do it.
Yes, excellent. So this is very correct. And then again, a question from the same person, Dr. Kirti Nahar, want to know, should we just leave out the millimeter part? Of course, we will not leave out the millimeters. We will mention millimeters, we will mention weeks, and we will mention days.
And more important.
Yes. And the millimeters comes first. Then the next thing, of course, is the fact that they're very happy to learn, Dr. Prachi Singhal in particular, that 36-week scan with Doppler should be becoming routine in patients who can afford it. And the ones who don't, then we say, okay, wonderful. We now have rules and we have guidances, and this is on YouTube and you can see it for yourself. There's a question from Dr. Kanchan Mukherjee. If a lethal fetal anomaly gets picked up in the third trimester, would the new MTP Act allow us to perform an ultrasound-guided feticide with expert medical board's advice? Which means that we deliver a dead fetus rather than a live fetus whom we then wait for the baby to die.
Anyway, you are saying that it's a lethal anomaly.
Yes, but should we let the baby then suffer for a few days and weeks?
So
or
the basic problem is when you have a huge ventriculomegaly.
Yes.
The mode of delivery becomes the question. I mean, that is going to be the problem. In that situation, probably you decompress them. But then I don't know whether we can do a reduction or a feticide and then deliver.
No, but that is the question, because sir, even if we do a reduction of that ventriculomegaly or anything, there will be some element of fetal pain and awareness.
Ventriculomegaly reduction. I'm saying
no, sir. The question is because at that point we have to be aware of that fetal pain and awareness. Would we, because once the law is accepting late terminations, would it be done with feticide or without feticide? I think that's a very valid question.
I wanted to ask you, Dr. Chinmay, is it more difficult to deliver a dead fetus than a live fetus? As a routine this thing, it doesn't make any
in obstetrics, no, because you're just waiting for the obstetric canal to open up. You have more time in a non-viable fetus because you are not in a hurry.
So can I give an
yes, please.
Bite? There was a patient in COVID time who came at around 24 weeks with an agenesis of corpus callosum with Dandy Walker along with that. By the time we confirmed, MRI done, so she went for termination through court. So from the court, she came back to us by about 30 weeks because she got COVID, because she had to go to a government hospital to get all things done. She got COVID, then she came out of COVID, so came to us at around 32 weeks. So at 32 weeks, doing an induction would be difficult and you'll get a preterm baby which will come out. So we waited till 36 weeks, then did a feticide, which was given in the court order itself that you need to do a feticide and then do a termination of pregnancy because it will come out with a live baby and you will have to take care of that child. So we waited till 36 weeks, we did a feticide on that and then we induced the patient and delivered. So we've done this for 2 to 3 patients in this COVID time.
So the court has given the order.
The court has given the order.
That's wonderful. That's very sensible.
Court is writing it in their order also.
But we should be careful that it has to be written somewhere. We should not take it on ourselves and do it.
Absolutely. You see, because the other implication is the fact that a potassium chloride could kill a mother. I mean, you know, once in so many 100,000 cases, we do find that a mother died of potassium intoxication when the potassium chloride was given. And so we have to be careful about that. And we must therefore have a complete informed consent when we do this kind of a reduction just prior to delivery. And the third thing, of course, is the question that when we are carrying out these procedures, we have to make sure that it's always done, like Dr. Chinmay said, with a written order and not without that. Then in terms of fetal pain, the fentanyl is a great option and is being increasingly used. And it would be wise, of course, to try to give the baby fentanyl and then do the whole procedure, because pain then becomes a major event. And in fact, some of us are even believing that anything beyond about 20 weeks should be fentanyl based. Now, there's one beautiful question that's been asked, and that's, please tell the total number of scans during pregnancy with timings. And if I may summarize what we've been saying, the late first trimester scan at 12 weeks and the anomaly scan at 19 weeks according to the present law, 12 and 19, and ideally also a scan at 30 and 36, which always includes the 30 and 36 should be a multi-vessel Doppler. So that would be an ideal situation. Everything else would be depending on patient affordability, patient request, and clinical situations. Have I summarized this adequately, and may I have some inputs from the panel?
Brilliant.
Yes, sir.
Brilliant.
Very nice. Chinmay, you're not putting any spanner in the works. Why is that so?
Because she doesn't have a spanner.
Oh, you agree. Very nice. Okay.
Sir, I would like to add that we should do one, between 7 to 9 weeks, or at least to diagnose that the pregnancy is viable and intrauterine.
So, yeah.
Yes, these things do add up depending on your local working conditions. I fully agree that this business of when a patient first comes in, just confirm intrauterine pregnancy, confirm that it's as much as it is possible to exclude twins and even have some sort of a dating of pregnancy at that time with respect to that ultrasound, not just one little gestational sac in one corner of a 6 feet by 6 feet space and 1 inch of embryo lying in the corner. So Chinmay already alluded to this. So that's what we should do. Wonderful. Thank you for that input, Dr. Asha Jain. Now, the rest of the questions are all related to the fact that if a growth scan is normal, again from Dr. Beena Mishra at 32 weeks, still the Doppler should be done and repeated. Well, at 32 weeks, if you're coming in for a growth scan, we will do Doppler. And in that case, then we will repeat depending on the clinical condition. If there's no clinical condition, at 36 weeks. Would that be fine? Yes. And then a very interesting question from Dr. Manohar Sivasamy. Is there separate charges for Doppler? We've already said something from a private practice point of view that we should tune our growth and biometry charges to include everything, including an amniotic fluid index, and to include the Doppler, and to include the fibroid and
physical
profile and so on. And therefore, there should not be separate charges. But if you feel that you're spending more time and you should charge more for a growth scan, then by all means, in private practice, you should charge for a growth scan. If the government institutions or any other institution were to do it, then they have their own institutional protocol. That is them. But in an ideal situation, a growth scan includes a Doppler. We know it's a fetal well-being scan, which will always include a Doppler. And we will look at amniotic fluid also. And therefore, there's no question of fractionating the charges. Wonderful. Now, let me see if there's anything else. I haven't had a chance to look at these questions because they came after we started our discussion. Some of these are not related to what we're discussing today. So I'm going to skip those and move on to the ones that have that. And Dr. Jasbir Singh again saying that, look, could we please make sure that this multi-vessel Doppler gets included? Well, we've made a good inroad into that today. And then this question of a growth scan at 36 weeks, and this is from Dr. Deepthi. Are we legally bound to look at every structure and anomaly? Dr. Taylor, you mentioned something about this.
Yes.
I understand that there are limitations in the scan at term because of fetal attitude, fetal position, ossification of the skeleton.
As much as you can.
As much as possible. And we can perhaps, if you're really unhappy about the visualization, we mention it in the body of the report and we mention it in the conclusion. So Praveen, would you agree with me on that?
Yeah, definitely. See, as far as possible, you have to look for, in case wherever there are limitations, mention those limitations.
Yes. Then there were some patients, then there were some of our doctors who wanted to repeat on some of this. Well, we will be putting this on YouTube. Our usual gap by the time we get permissions and clearances from copyrights is about 3 to 6 weeks. So please bear with us. But everything of this will be on YouTube within 6 weeks. And that's what we should do. Then the question from Dr. J. Desai, and this is again open for the panel. Should we perform a biophysical score for 30 minutes when a patient comes with decreased fetal movements in the 3rd trimester? Or is it enough to say that, look, I saw one fetal breathing movement and now I can stop?
I think how many of us have got 30 minutes to do a biophysical score?
Well, that apart, when a doctor asks me this question, I have to give a doctor a clean answer. I cheat, that's a different matter. But the question is, if I don't cheat,
based on
see fetal breathing, then do I just stop?
I mean, I would stop.
You have to look for one episode. You've got that episode. What's the point?
Yeah, because the thing is, fetal tone and they will get hampered. The respiration gets hampered the first.
That's right.
If you're already seeing a good 30 seconds respiratory movement,
yes,
I think you can stop.
See, it is all interrelated in the sense, once the amniotic fluid comes down, naturally the baby tone as well as the fetal body movements will also be reduced. The only independent factor is the fetal breathing movement, because it is basically controlled by the brainstem. So that is the reason why we give that importance, or else there is nothing else.
Yes. Dr. Vandana Bansal, what is your opinion on this limited relevance of the biophysical profile?
biophysical profile, as we were all discussing, fetal breathing movement, only one is required in 30 minutes. So it doesn't mean that you have to have more breathing movement or you have to look for half an hour. If you see one breathing movement, it is enough. So you basically, we look at modified biophysical rather than doing a full biophysical profile, which includes only the NST and an AFI.
AFI.
So if your NST and your AFI is good enough, in a patient who has got a good growth and Doppler, then I would be happy with this rather than looking at tone and movements and breathing movements. So this modified of AFI and NST is what we routinely do, which is not difficult and it doesn't require half an hour to look at movements and breathing movements. So I think modified biophysical is good, but between Doppler and biophysical, Doppler is going to take away all our decisions for management and the decisions for delivery rather than the biophysical profile.
Because it's based on active performance. Biophysical is more passive.
Yes, and wonderful. And then can we please re-emphasize and answer Dr. Madhvi Lata's question? 34 to 35 weeks with average for gestation age, all parameters are normal, except the cerebral placental ratio and the middle cerebral artery, which are less than 5%, as she puts it. Then how to follow this case? So what I will do is that we won't answer it here because this is really about the timing of scans in a very specific situation. And we have excellent webinars available on how to follow these up. And we'd leave this question for that. The question I do want to answer now is, before we close, our last question for tonight. And that is, I have this girl who's less than 18 years old and she's unmarried and she comes in and then obviously pregnancy. What should be done?
Inform the police.
In the sense that how much of a scan, pregnant, not pregnant, full anomaly scan, full dating scan, full Doppler, full everything, or we just
to continue pregnancy, I think we should do.
This case is complex, sir. The whole background is complex because she's 18 years and she is unmarried, she's pregnant. There are legal issues with this.
Yes.
So I think this has, I mean, in an open forum, it's very difficult to handle such a case as such. Legal authorities have to be involved because there are provisions in the country against this, and you are liable if you don't inform it.
That is true. So this is a whole topic by itself. And so we will, my answer to Dr. Deepak Varshan is that we will perhaps use this as one of our topics in the future and come up with what we should do in this situation and develop a protocol as well. We have another interesting suggestion for one of our future topics, and that is on how to report an obstetric scan. And Dr. Shubhangi Mundada would like us to talk about that. We promise to include that in the near future. And with that, thank you indeed very much, panel, for being right here to the end. I know we've overshot by about 15-20 minutes, but we just could not answer these questions. Thank you indeed, each one of you, for helping out with this and giving us these enlightening answers.
Thank you.
Thank you, Khurana sir. Thanks a lot on behalf of our society. I thank you for holding such a discussion that has everybody sitting up and listening. Even at the end, we have more than 200 people. And I thank Praveen sir and Dr. Bimal Sahni, Dr. Chinmay Rath, Dr. Vandana Bansal, Dr. Vaishali Munde, all of you who have contributed to the panel and have spent your evening with us. I thank you all for being here and sharing your knowledge. And I hope we continue to do this in the future. Thanks a lot.
Thank you.
Thank you very much. Namaskar.
Thank you very much. Good night.
Good night.
Good night.